Hello, my name is Alexis Valenzuela. The talking about is low-dose metrotexate for the prevention of atherosclerotic events. Definition.
Welcome to another Patho video. The topic of this video is atherosclerosis. Atherosclerosis is a condition where lipid plaques form within the walls of arteries. It is a specific type of arteriosclerosis, which is the generalized condition of hardening of arterial walls, whereas atherosclerosis is specific to the buildup of lipids that cause arterial walls to narrow and restrict blood flow. Atherosclerosis can be especially dangerous for the heart, since it often affects coronary arteries, which supply oxygen and nutrients to the heart. In severe cases, when blood flow through the coronary arteries is cut off, a heart attack, also known as a myocardial infarction, can occur, where heart cells and cardiac myocytes are deprived of oxygen and they die. Normally, most of the low-density lipoproteins, or LDLs, pass through the endothelial cells by transcytosis from the blood and then enter body cells by receptor-mediated endocytosis to be used in normal cell processes. The progression of atherosclerosis begins when the endothelial cells of the arterial wall become damaged. This can be caused by hypertension, smoking, hyperglycemia, and hypercholesterolemia, which is an increased number of LDLs in the blood. Endothelial cell damage increases the permeability of the arterial wall, allowing LDLs to enter the tunica intima. White blood cells, such as monocytes, normally move freely through the blood vessels and do not attach to endothelial cells as they stream past. However, when endothelial cells are exposed to irritating stimuli or damage, they will express adhesion molecules that can capture nearby white blood cells. These white blood cells undergo morphological changes that allow them to flatten and squeeze between endothelial cells. This movement of white blood cells out of the bloodstream is called diapedesis. White blood cells are capable of producing free radicals. When these free radicals come in contact with LDLs, oxidation occurs. Oxidized LDL particles are especially effective at attracting and activating white blood cells. White blood cells then engulf the modified LDL particles, which stimulates them to produce even more oxygen-free radicals. It becomes easy to imagine that an area of endothelial damage will lead to an accumulation of modified LDL particles in migrating white blood cells. A positive feedback situation begins to arise when accumulating immune cells and modified LDLs bring in even more immune cells and modified LDLs. Macrophages in the tunica intima start to engulf modified LDL particles. Ultimately, this leads to the production of a cell called a foam cell. A foam cell is saturated with LDL particles, and the excessive amount of lipid in the cell gives the cytoplasm a foamy appearance. Foam cells ultimately die and release their contents, which are then quickly engulfed by other nearby white blood cells. Please note that the animation shows smooth muscle cells also engulfing LDL cholesterol. Eventually, the accumulating lipid from the processes just described and the fragments of dead cells produce an area with a lipid core that begins to form a plaque. Endothelial cells cover the plaque. The plaque accumulates calcium salts and more dead cells over time, and it will harden. This plaque in the arterial wall is atherosclerosis.
What is metrotexate? Metrotexate is a structural analog of folic acid. that competitively inhibit the enzyme rehydrofolate reductase, acting as an antimetabolic on cell recruitment. It has immunosuppressive and anti-inflammatory properties. Application in medicine. Low-dose metrotexate is the most widely used drug for systemic rheumatic disease worldwide, and is the recommended first-line agent for rheumatoid arthritis. Metrotexate has been the most widely used therapeutic adjunct in modifying the course of chronic inflammatory disease, but beyond and intestinal in the last 12 years.
So the cardiovascular inflammation reduction trial, for me, is fascinating because at first sight, the implications are, here's a negative trial, but actually it tells us something really interesting about the biology. We know that the IL-1 beta, IL-6 pathway from the inflammasome is implicated on the basis of the previous CANTOS study. Now here's a different approach without selecting individuals at high CRP. Using amount of metrotexate that was sufficient to influence the hematological markers, but it did nothing. And it did nothing to the IL-1 beta, IL-6 pathway. So I think that this tells us that that pathway is crucial in terms of modifying inflammation and plaque behavior.
I was surprised it didn't lower C-reactive protein, and Dr. Richter is the PI. So why did Dr. Richter choose a drug that doesn't lower C-reactive protein to test? But it certainly is a nice trial to show that you can't just use any old anti-inflammatory drug. You have to use ones that meet specific pathways. And certainly with the results of the CANTOS trial, the IL-1 pathway appears to be the one to approach. But it didn't disappoint me or discourage me about the idea that directly targeting inflammation can still be beneficial for cardiovascular patients.
I think that with each of those trials, we've got to specifically look at that pathway. And we've got to look at the questions of, is the extent of dose sufficient to modulate that pathway, the plaque? Because if not, we may be facing another negative trial. There have been some interesting trials with colchicine already that look encouraging, but they were small.
And so I would like to have some sort of direct anti-inflammatory agent that has been demonstrated to help cardiovascular patients available to my patients. And then I'm also excited about the low-DOPA2 trial because colchicine is inexpensive. It's been shown to be very safe. It's already used for not only treating gout, but for treating other cardiovascular things such as atrial fibrillation and pericarditis. And so it might just fit right in if it becomes evidence-based by the low-DOPA2 trial. So I'm excited about that. And I'm also excited about other agents that might be targeted. Now that people know which direction to go, there have been other anti-inflammatory agents that have not worked. And so now we might have some that will work, especially now that we should probably concentrate on the IL-1 pathway.
Pros and cons.
Canakinumab is a selective human monoclonal antibody against interleukin-1 beta, a pro-inflammatory cytokine that has been implicated in the development of atherothrombotic plaques. Increased interleukin-1 beta activity leads to elevated levels of high-sensitivity C-reactive protein, or CRP, a biomarker associated with an increased risk of coronary heart disease. Previous trials have demonstrated greater cardiovascular benefits from statins in those with elevated levels of high-sensitivity CRP before treatment, and when lower levels of high sensitivity CRP are achieved with treatment. However, it remains unclear whether reducing inflammation without lowering cholesterol would prevent cardiovascular events. Investigators tested this hypothesis in the large double-blind CANTOS trial, which enrolled patients with a history of myocardial infarction and high-sensitivity CRP levels of more than 2 milligrams per liter. 10,061 patients were randomized to 4 groups: subcutaneous injections every 3 months of 50 milligrams of canakinumab, 150 milligrams of canakinumab, 300 milligrams of canakinumab, or placebo. At baseline, the median LDL cholesterol level was 82 milligrams per deciliter. Throughout the trial, patients in the canakinumab groups had significantly lower high-sensitivity CRP levels than those in the placebo group. LDL cholesterol levels were not reduced with canakinumab. The primary endpoint included non-fatal myocardial infarction, non-fatal stroke, or cardiovascular death. The median follow-up was 3.7 years. After adjustment for multiple testing, the 150 milligram dose of canakinumab, but not the other 2 doses, significantly reduced the rate of the primary endpoint. Rates of neutropenia, thrombocytopenia, and fatal infection or sepsis were increased with canakinumab treatment. The authors conclude that targeting interleukin-1 beta with canakinumab at 1 of 3 doses every 3 months reduced atherothrombotic events, independent of lipid lowering. Full trial results are available at nejm.org.
Roles. Low-dose metrotexate is an inexpensive aesthetic and we will use it treatment for inflammatory conditions, including rheumatoid arthritis, psoriatic arthritis, and juvenile idiopathic arthritis, due to its effectiveness in delaying anatomical damage. Low-cost safety and low therapeutic segment in patients with rheumatoid arthritis and psoriatic arthritis who receive low dose. Metrotexate have fewer cardiovascular events than patients who receive other therapies or placebo. Counts. Evidence of risk factors for severe metrotexate toxicity suggest that creatinine clearance are less than 79 ml increase the risk of severe pulmonary toxicity and that hypoalbuminemia in this patient is related to heparin and pulmonary toxicity. Issue applied in Ecuador. Conclusion. Coronary disease is one of the main causes of death throughout the world. Among patients with stable atherosclerosis, low-dose metrotexate did not reduce interleukin-1 beta, interleukin-6, or C-reactive protein level did not produce fewer cardiovascular events than placebo.
Vicious cycle, as you'll see. And don't forget that LDL is also still being deposited into the wall from the bloodstream. And as part of this inflammation, more and more endothelial cells get damaged. So I'll move our drawing down even further so we can look at the next sort of development. And so you can see this mountain of cholesterol and bone cells, dead macrophages that are filled with cholesterol. You can see this mountain just keep on building and bulging out into the middle of the blood vessel. And so by now things are just way out of control, right? And these guys in here, this is the smooth muscle part of the artery, by the way. So this is the smooth muscle layer. These guys start to take notice, these smooth muscle cells. So what ends up happening is that you get smooth muscle cells that sort of migrate out of the smooth muscle layer and they sort of migrate. I hope you can see this. I'll draw a little bit thicker. They start to migrate out of the smooth muscle layer into the fatty plaque here, right? Because they can sort of sense that something's just not quite right. And what they start to do is they really want the plaque covered up, because they don't want the thrombogenic, remember thrombogenic means clot forming. They don't want the thrombogenic plaque to be exposed to the blood. So what they start to do is they start to secrete a fibrous cap. They sort of spit out this collagen and elastin protein cap that covers up, right? So I'm drawing it in purple, that covers up this plaque and shields it from the bloodstream. And that's called a fibrous cap. And they also do something else. The smooth muscle also do something else. So you remember these foam cells that died here? Well, when they release their signals after they die, they induce the smooth muscle into depositing calcium into the plaque. So I'll draw that in. I'll draw in these little calcium crystals now. So you can see it's just starting to look like a mess in here. There's just all sorts of stuff going on. So again, it's just really not something you want to have happening in your body. And so just by looking at this, what can we say is happening to the blood vessel? Well, I mean, we can see this huge bulge. We can see that the plaque is obviously bulging into the blood vessel, and it's probably going to restrict the flow of blood that can get through here. So that's one thing that atherosclerosis is doing. It's occluding, it's blocking off the arteries. The second thing is, well, look at this calcium. I mean, if there's one thing we know about calcium is that it's really tough, it's really hard. And so this by the smooth muscle laying down calcium, that's one of the ways that atherosclerosis makes your arteries really hard. And that's actually part of the name. Atherosclerosis actually means hardening of your arteries. But I think in terms of coronary artery disease, the biggest reason that atherosclerosis is bad is because it can cause complete blockage of the artery. And that blockage of the artery can happen because sometimes this plaque, this fatty plaque, it can rupture. And when it ruptures, all this thrombogenic plaque material gets exposed to the blood. And when it gets exposed to the blood, it starts to form this really big blood clot in the middle of your artery, in the middle of one of your coronary arteries. So let's just draw that in here. Let's just draw this big blood clot. Pretend that this has been ruptured and this yellow thrombogenic material has been exposed, and this big blood clot's going to form. By the way, I'm originally from Jamaica. Blood clot is a bad word in Jamaica, so I apologize to any of my Jamaicans who are watching this. This big clot can form, and it can totally block off the blood vessel. And when that happens, no blood can get through, right? So this is really the biggest reason that we don't want atherosclerosis to be happening in our coronary arteries, because you can see that we've blocked off the blood flow. And if blood isn't allowed to get past this clot and get to the piece of the heart that it's supposed to be serving within about 20 minutes, then you get irreversible damage and death of that piece of heart muscle. So for example, what we drew is this little piece of artery here, right, in blue. So if a atherosclerotic plaque and a clot developed right there, as it has in our vessel here, then that would be really, really, really bad. Because, you know, all the blood for this whole part of the heart is coming from this upstream vessel. So without getting blood flow through this vessel for about 20 minutes, if this clot sort of persists for about 20 minutes, all of this heart muscle would start to die off. So that would be a massive heart attack. And actually, let me just clarify. So we say heart attack, but in medicine, we refer to a heart attack as a myocardial infarct or an MI. So myocardial just refers to heart muscle, cardia for heart, and myo for muscle. So heart muscle, and infarct means death of tissue due to lack of oxygen from lack of blood. So a myocardial infarct is death of heart muscle due to lack of oxygen. So here we've had a myocardial infarct due to this big plaque that developed here.
Thank you.